Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred to me. This patient had cataract surgery done 27 years ago, and the patient had a Rezoom multifocal IOL. She was very happy with her vision in this eye. Well, she came in with sudden loss of vision and was found to have a dislocated lens implant, was referred to see me. And so we had a long discussion about what we should do. She said, I really like the vision in this eye with this lens, and I talked to her if we took it out. Most of the multifocal lenses that are out there, the modern ones, are one-piece lenses. We can't really put that in the eye with sutures and so forth. So it makes it more challenging. I told her it would be much easier to put a monofocal lens with a Yamane technique. Well, long story short, she chose to try to keep that Rezoom lens. I tried to suture and lasso the lens with using Gore-Tex, and I did a vitrectomy, did everything the way I normally do, and the lens dislocated. And so I abandoned trying to use Gore-Tex to loop around the haptics. Again, not the ideal technique for this situation, but because she wanted to keep that Rezoom lens, I gave that a shot. After it failed, I talked to her again and said, okay, we can try to scleral fixate this lens, but it's 27 years old, and I don't know if it's durable, if there's been degradation of the material over time. And doing the Yamane technique can be a little bit of stress on the haptics. But she wanted to give it a try, so we went ahead and gave it a try. And so this is the lens. You can see it's dislocated. Again, I've done a vitrectomy already. I'm making my marks first on the right side on the limbus, and then using the cannula to find 180 degrees apart, I make another mark on the other side. I'm checking with the cannula, making sure I'm completely bisected in half. Using the caliper, I'm going back 2.5 millimeters posterior to the limbus, indenting, and then using the tip of the cannula to mark. And then adjacent to that, 2 millimeters. Caliper on the left side as well in similar fashion. You always want to dry the surface when you do this. If you don't dry it, it's just going to bleed everywhere. And so the ink. And so you want to just make sure it's nice and dry and pat, and then you can have your assistant put some ink on the tip of the cannula to do that, and you're able to get nice pinpoint marks this way. I'm making my contralateral incision for the externalization of the leading haptic technique. And then I'm making another paracentesis incision. Mind you, I've already done a full vitrectomy on this patient before when I tried to do the Gore-Tex lasso technique. So this is some dispersive viscoelastic to fill the anterior chamber and coat the corneal endothelium. Now this patient, it's very unusual. She has somewhat of a sulcus, but it's really very unstable. There's some peripheral capsule support and so forth. And so this lens is not, about to fall into vitreous or anything like that. But nonetheless, it's clearly not stable because it slipped out. So I'm making my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of groove tunnel, and then enter. This is my right needle. I'm bending it 90 millimeters from the tip, and the bevel is facing towards me for the right needle. The left needle, I'm bending at the hub, and the bevel will be facing away from me. Again, the bevel is always going to face the approach of the haptic. And I like to have the haptic and the needle facing and being in the same plane. And so I'll tell you what I mean by that in a second. First, we have to externalize the leading haptic. As you can see, the haptic is 90 degrees away. So we have to kind of nudge it, try to get it into alignment so I can externalize the haptic. And this is before I developed the 25 gauge needle docking technique, where I dock the leading haptic on the bevel of the needle and slide it out. By doing it this way, it's the most atraumatic way to get the haptic out. You saw right there, I was a little bit hesitant. I didn't get a good grip of the tip of the haptic. I didn't want to damage it, so I let it go. And so I'm going to go back after it again, because the last thing you want is you bend the end of the haptic and then you're toast, and then you can't use this lens. So I'll go ahead and try the handshake again, grabbing it with microforceps on the inside, hand shaking it to the forceps on the outside, and it comes out. Now I have to externalize the trailing haptic as well, and so you see here I'm going to go ahead and, with the closed forceps, I'm going to lift the optic up a little bit, nudge it. You can see the trailing haptic is emerging, and I'm able to pull it out. So I'm just repositioning the haptics. And now we're going to inject some more viscoelastic to fill the anterior chamber, pushing more viscoelastic in the area where I'm going to pass my needle, grabbing the limbus with the forceps, keeping the eye in the neutral position. By doing it this way, the conjunctival mark will reflect the intended scleral needle pass. I'm tunneling 2 millimeters and then diving down. You can see the eye was in the neutral position, and therefore, when you're doing it this way, the lens is going to be in an excellent position with a very low risk of tilt and decentration. You can see the bevel is facing towards me. I'm going to now get my microforceps, grab the trailing haptic. Because the leading haptic is externalized, it's so easy for me to grab it, dock it on the bevel of the needle, and then slide the haptic into the needle. And it went very easily. Again, this is all because I've externalized the leading haptic through that contralateral limbal incision. There's no torquing, there's no stretching, there's no pulling, there's no yanking, there's no stress on the haptics with this maneuver, doing it this way. And that's very important when you're dealing with an implant that's 27 years old and in the eye here. You can see the haptic is even kind of not blue, it's lost its blue color over time. Carefully internalizing the leading haptic with microforceps, pushing some more viscoelastic and over that area where I'm going to make my needle pass. Grabbing the incision with microforceps and then placing the needle into the sclera, embedding it and tunneling it 2 millimeters and then diving down. You can see I'm making sure I get a nice shelf. You need to push the needle through the sclera 2 millimeters. You need to make sure you get an excellent tunnel, because without a good scleral shelf, you're going to have potentially tilting and so forth of the lens. Now look at here. I'm going to dock the haptic on the bevel needle. This is important. See me with my left hand, I'm going to slightly rotate right there so that I have a better angle. I flatten it out. I was able to cannulate the needle with the haptic very easily without any trauma, without any traction, without any pulling on the haptic. This is a very gentle technique on the haptics. Start to pull the needle out and then making sure my microforceps is ready to grasp the haptic, making sure not too much of the haptic comes out of the eye. Cauterizing the tip. You want to get a nice little flange, but obviously big enough that it's going to hold. You want to have your microforceps ready to grasp the haptic as the needle is being pulled out. So you can see there's not much tension on the lens or the haptic here. I'm able to pull out the needle, the haptic is out, and then I'm going to cauterize the tip in similar fashion. I'm going to push the haptic flush to the sclera, trying to embed the haptic into the sclera itself. And as you can see, this is a perfectly centered lens implant, and that's all because of my scleral needle placement. Marking and making sure you execute the passing of the needle through the sclera is what dictates whether or not you're going to have a well-centered lens without tilt. I pre-placed my tononylon suture, and then with the IOP drop down to 20, I'm removing the viscoelastic from the anterior chamber. Again, I should not have any vitreous because I did perform a vitrectomy before when I tried to attempt the scleral fixation of the cortex. If you pay attention, you'll see the white cortex on the right and left sides of the eye there. You can see that little track of suture. And as I'm doing this, I do not encounter any vitreous throughout the entire case. So again, the important point is you want to tunnel through the sclera with the needle. If you don't have a good tunnel, that means you won't have a good shelf for the haptic to lay on. And if you don't have a good shelf, then the lens and the haptic will sag back. And if it sags back posteriorly, it can result in tilting of the lens. And if you don't mark properly and you don't have your marks 180 degrees apart, then you might have decentration. So again, none of this is really difficult, but it's tedious, and attention to detail is the most important factor when you're doing these cases. As long as you have that attention to detail and you execute the surgery considering all these nuances, you can achieve a well-centered lens without much tilt. Now that I've removed all the viscoelastic, I go ahead and tie the suture down and then bury the knot. And this is going to be the vitrector assisted PI. Again, because I don't have any trocars, I could have done the irrigation through a paracentesis, but I decided to do it through the main incision because it was a nice tight incision. And I'm doing the PI, again, temporal. This is the low cut rate setting. By doing it this way, you can see there's a really nice, well-controlled, small-sized peripheral iridectomy performed. And then I'll hydrate my incisions, and this is the end of the case. So again, this is the patient who had a dislocated lens, wanted to keep the Rezoom lens. I tried to lasso the haptics with Gore-Tex, but because of the configuration of the haptics, it slipped out. The patient came back with another dislocation. I had a long discussion with her about trying to perform scleral fixation of a lens that's been there for a long time. And I told her, quite frankly, I've never done that. She wanted to give it a shot. We went ahead and put the Rezoom lens and scleral fixated it. I did my modified technique by externalizing the leading haptic. There was very little trauma or torsion on the haptics. When I see other folks doing Yamane technique, since they're used to using the C2 Lucille lens, I've noticed that they're pretty tough on the haptics. And you can do that on that lens because it tolerates it, but these lenses, especially in a patient with PMMA haptics like this one, a PMMA haptic is not going to tolerate that. If you roughhouse it, the haptic will break, especially in a lens like this that's in there for 27 years. And so this patient had a refixation with a Yamane technique, my modified technique, and it was a well-executed surgery, and the patient had an excellent refractive outcome. This patient, previously, this lens was slightly on the near side, so she had a little bit of a mini monovision type of deal where this Rezoom lens was in the non-dominant eye. And so we ended up a little bit minus in this eye, but the patient was quite happy with her result. At the end here, I'm going to inject some subconjunctival lidocaine and then some Ancef at the end of the case. And you're going to see another point here. This patient was quite happy with her refractive result. Her other eye is 20/20 distance, and this eye is J1 plus near. But this is a lens postoperatively in the clinic. You can see a perfectly centered lens of this, again, Rezoom lens implant. You can see the iris transillumination defects from where there was the dislocation and chafing of the iris with the lens. And you can see the haptic, which is embedded in the sclera. You can see how flat it is. And again, it's not pooching upward. It's flat, embedded in the scleral tissue on this side. You see quite a bit of the color of the haptic, and same on this other side. And by seeing the color of the haptic, seeing its flat profile, it means I achieved a good scleral tunnel and therefore a good scleral shelf when I executed the technique. And that means passing that needle through the sclera before diving into the vitreous space. I think a big mistake that some people do is they don't pay attention to that scleral shelf. And you need to have a good scleral tunnel in order to be able to execute the surgery properly. By doing it this way, the risk for erosion should be very low, because if the haptic is pointing up, out from the scleral plane, that's when you can get erosion. That's when you can get potentially endophthalmitis. Thankfully, I haven't had that situation arise. But you can imagine if you don't have a good scleral shelf, the haptic is going to be pointing up, and that's when you can get erosion of the haptic through the conjunctiva, and complications. So that's the other point, is executing the scleral tunnel properly, making sure the eye is in a neutral position, and by utilizing my modified technique, by externalizing the leading haptic through the contralateral limbal incision, it makes the execution of cannulating the haptic through the needle so easy and really atraumatic to the haptics. I've done this repositioning technique on quite a few patients now. You might say, why should you do that? Why would you save a lens versus remove a lens? Well, if the lens itself is fine, there's no sense in abandoning it. If you have to do an exchange, you have to remove the lens, do a vitrectomy, and it's a lot more surgery involved. If you have a patient like this, you can reposition the lens. Yeah, you might still have to do a vitrectomy, but by saving the lens, you've saved yourself a lot of steps, and you've also saved the patient quite a bit of surgical maneuvers. And so I think it really adds a certain element of safety. It's less surgical manipulation. And if the lens is in good condition, you might as well use it if you can. So this case illustrates how you can refixate a lens that's 27 years old in the eye with the modified Yamane technique, intrascleral haptic fixation, and this patient did exceptionally well. So I hope this was helpful to you, and I thank you for your attention.